So the historical background of diarrhea globally. So I'm going to give you a couple of cases before we start that, and we'll return to these cases at the end of the talk. So the first case is of an 8-year-old male who presents to your clinic with complaint of persistent diarrhea, so defined as daily loose stools, 3 to 6 times a day, no blood, otherwise well. Now this could be a child that you see in clinic in Cameroon, or for me, could be a recent refugee from Burma who lives in government housing. There's a communication barrier in terms of what I'm able to extract from the interview. Notably, the weight and height of this child are less than the 5th percentile, and the exam is otherwise normal. So just as we go through this talk, kind of be thinking along what would next steps be. And then the second case is of a 26-year-old female. So you might wonder, why is a pediatric gastroenterologist seeing a 26-year-old female? It's actually because we see up to the age of 24, 25, 26 in peds GI here in the US. So this is a 26-year-old female who might present to your internal medicine clinic with complaints of persistent diarrhea, daily loose stool, bloating 2 to 5 times a day, no blood, otherwise well. This particular patient as an immigrant from Pakistan, is now working as a doctor here in the US. And she used to think her diarrhea was infectious, but now that it's persisted, she wants to know, well, are there other things that she needs to be worried about? She's very thin, so her weight's less than the 3rd percentile. Her height is greater than about the 50th percentile. And her exam has some notable findings of pallor and clubbing of her fingers. So again, in this situation, what would be your next steps? Okay, so just think of that as we go through the talk. So going back to sort of the historical background of diarrhea globally. So this is just, kind of to tell you a lot of what we've learned of the origins of IV fluids. So normal saline, lactated vinegar, comes from the analysis of stool and blood from people who were really dehydrated due to diarrhea. What was interesting at that time, though, so this is from the this is from the Lancet 1989, but this talks about way earlier times. What was notable then was IV fluids was only given to the sickest of patients. There would often be inadequate volumes given. It wasn't sterile, so it's not the sterile bath that we use here, impure and hypotonic. So then what went from the 1800s, from the slide that I just showed, to now in terms of events? So mortality from diarrhea used to be greater than 75%, so 2/3 of patients or 3/4 of patients would die. And then as the advent of IV fluids, figuring out, well, you shouldn't just give sugar and saline, you should give potassium also, then adding oral enteral feeds, and then subsequently cholera epidemics in Asia, leading to the discovery and development of ORS, really has made the mortality drop down from 75 to 80% down to 2 to 3%. And these are global numbers.